get started. So welcome everybody. This is a Shame and Medicine seminar in our Shame and Medical History seminar series, and you're all very welcome. My name is Luna Dolezal, and I am the PI of the Shame and Medicine Project, which is a Wellcome Trust funded project based at the University of Exeter in the UK. And our project is also based in the Centre for Cultures and Environments of Health, which also hosts this seminar series. So you're all very welcome. And I'm really happy to introduce Mara Pieri, who is here today to speak to us about shame, pride, and all the invisible things. And I'll just tell you a little bit about her before I hand it over, and she'll share her slides and give her presentation. I should also say we've got an hour and a half blocked out for this talk, and I don't know how long you're going to present, Mara, but after that we'll have time for discussion and questions. This talk is being recorded, and it's our habit to put all of our talks on a YouTube channel. So if you don't want to appear in the recording, you're welcome to keep your camera off and just type in the chat if you have questions. Sometimes we don't include the question and answer time. So if you prefer we didn't, you can just let us know. But I'm very happy to introduce Mara. She's an associate researcher at the Centre for Social Studies at the University of Coimbra, and she has a PhD in human rights in contemporary societies. And in 2023, she published LGBT plus people with chronic illness, chronic queers in Southern Europe, published by Palgrave, and is currently conducting research on access to healthcare services for the LGBTQ plus population in Portugal. So I'm really happy to introduce Mara, and I'm going to hand it over to you to share your screen and your slides and to give your talk. And then when you're done, I'll moderate a question time. Thank you.
Thank you so much. Thank you, Luna, and thank you, everyone. I'm so happy and excited to be here because as I was sharing with Luna, I'm a big fan of the YouTube channel. I've been following the previous seminars, and also it's a great honor to share a bit of my research also within this framework of the Shame and Medicine project, which I admire. So let me just start with sharing my slides. Yes. So today, as you can see from the title, I'm going to speak a little bit about access to healthcare through the lens of emotions and feelings. As Luna was saying, I am a sociologist. Although I am not a sociologist of emotions, I'm a sociologist of health, and I work on health and illness and access to healthcare. And when we talk about access to healthcare, in many cases, we often talk about structures, we talk about inequalities, we talk about factors of risk, and so on. And I feel like the emotional dimension is often overlooked, and so what I'm going to discuss with you today is the results, some preliminary results of a project I'm conducting right now, and through this lens. So I will first give a brief introduction on LGBTQ plus access to healthcare, what we mean by that, what is the state of the art, just to be all on the same page regarding the topic. And then I will briefly present the diverse project, diversity and equality in access to healthcare, which I am currently coordinating. And then I will discuss with you some of these results that have to do with the challenges of grappling with invisibility, visibility, and discomfort in accessing healthcare. So when we talk about LGBTQ plus access to healthcare, we talk about many different things. But literature is not as scarce as it was in the past years, although and now in the past 2 decades there has been a growing interest in getting to know more, what do LGBTQ plus people feel, what are their experiences when they access a health service. One of the topics that is recurrent in literature is the issue of invisibility. Literature and studies conducted in different countries show that there is a tendency to not come out to healthcare professionals and to not feel safe to come out. And we will discuss that a bit more in a bit. But also, there is a scarce representation of LGBTQ plus people, we could say, of diversity in studies that has to do with anything that has to do with health issues and pharmaceuticals and so on. And of course, this is another issue that is very dear to me, is the invisibility of the LGBTQ plus healthcare professionals within the healthcare system. This is also the topic of a project that I've just started, which is called Pulsar, and in which Luna is also part of the advisory board. Today, I will not have the time to address this topic, but I really wanted to signal that it is an important one within this broader topic. Then other studies also show that the LGBTQ plus community often show less compliance, lower levels of compliance to screenings, to what is considered non-urgent care, as for example dentistry, and less compliance to the therapeutics, so to, for example, to take medications and so on. Of course, I am talking about the LGBTQ plus people as if it was, it's a big umbrella. And within this big umbrella term, there are a lot of differences. And of course, we need to always look at these differences also through an intersectional lens, because LGBTQ plus people are also embodying different positionings in terms of age, of able-bodiedness, of race. And so they are also challenged by different discriminations that are not only related to sexual orientation and gender identity. So this is also a very important point, the fact that when we look at LGBTQ plus people accessing healthcare, we need to keep in mind an intersectional lens. At the same time, there is an undeniable history of pathologization of homosexuality and of trans and non-binary identities in medicine, in the medical history. And within this seminar series, it has been discussed by different colleagues. So for a long time, the history of medicine has coincided also with a history of thinking about homosexuality and trans and non-binary identities as, for example, mental illnesses or something that was wrong. Okay, so, and this history of pathologization, of course, is still very much present today, although many other things many things have improved, of course. And finally, there is evidence that in general the LGBTQ plus community suffers from poorer mental health and in general, but of course we also needed to think about that intersectionally, and then we will have to unpack that within the LGBTQ plus umbrella. But just to give you a brief introduction to these are the four, let's say, main topics that come out when we talk about LGBTQ plus access to health. So the main issues that need to be kept in mind and addressed. So together with a growing literature on LGBTQ plus access to healthcare, in the past decade, there is also a growing interest in rethinking LGBTQ plus health, in sort of rethinking the way we think about health and healthcare. And as different academics have underlined, we need to recognize that actually the way we think about health issues and organize healthcare puts a supposedly neutral subject at the center. And this neutral subject is usually or mostly cisgender, male, white, heterosexual, able-bodied, slim, and so on. And so by acknowledging this bias that influences the way we structure the whole healthcare system, we need to make also a theoretical effort in what Zeeman calls a destabilization of the way we think about health and healthcare. And I quote from Zeeman: critical and queer theory collectively seeks to destabilize, deconstruct, challenge, or reimagine dominant binaries, discourses, normative categories, or moral ideals, structures, relations, and practices in health and healthcare. So there are sort of two big movements within this interest in LGBTQ plus health. On one side, the research that is addressing data and experiences from the LGBTQ plus community accessing healthcare, but on the other side, also a theoretical effort to rethink and critically restructure the way we think about health. And this, of course, has many intersections, for example, with critical disability studies, with creep theory, and so on. Just to give you a very brief contextualization, the project I'm working on and I will present today is based in Portugal. And Portugal is this little land here on the western part of Europe. And it is usually very well positioned in the ILGA map. You know that the ILGA map every year presents results on the advancement of LGBTQ plus rights in a country based on several indicators. We must say that Portugal has been steadily growing in the past 20 years in this map. And in the past 20 years, many achievements in terms of recognition of LGBTQ plus rights have been reached. At the same time, a bit like other countries, and the UK is one of them, in the past 2 or 3 years, this positioning has been also decreasing. So last year in 2024, Portugal was on the 7th position. And yesterday, just when I had finished my presentation, I had to come back to it and give it a final touch, because just yesterday, the ILGA was published the 2025 map, in which Portugal is occupying the 11th position. So it is also important to note that Portugal is a small country. It has more or less 10 million people, and it is one of the few countries in which there is a national LGBTI health strategy, which is promoted by the Health Ministry since 2019, and it regulates somehow the politics around LGBTQI health, especially in the public sector. And the last achievement in terms of LGBTQ plus health in Portugal was the end of the ban on blood donations for gay men that was actually still in place until last year. So there is a lot of work that has been done, but there is still a lot that can be done in the future. So the project I'm going to discuss today, and just very briefly, is just to give you a contextualization, is a project on diversity and inclusion in access to healthcare, and it employs different methodologies. But the results that I'm going to show you today are based on an online questionnaire that included mostly people, young adults. And about their experiences in access to healthcare services, followed by some in-depth interviews that are more focused on personal trajectories and in the elaboration of recommendations that come from the experience of individual people. Participants are very diverse in terms of sexual orientation and gender identity, and age and other indicators. I just wanted to show you a little bit of this, just because I always think it's interesting to look at data from what they actually show us of surprising, and something that actually surprised us was the fact that there is almost a 20% of people that self-identify as non-binary, which is, of course, a reflection of contemporary LGBTQI community, and also 33% of participants that self-identify as bisexual. And I also find this very interesting, consider that the bisexual identity is often overlooked in research on LGBTQ plus community. So what I'm going to do today is sort of combine a little bit of what came from the quantitative data collection and the qualitative data collection, and sort of dialogue through these two inputs. So the first theme, the first topic, as I told you, is almost always the topic of invisibility. And I want to start by one of the questions that we actually asked our participants, and before this question we asked whether they do come out or not to healthcare professionals, and then we get to this question in which we ask, think about the situations in which you chose not to come out to the healthcare professionals you encountered. What were the main reasons for your choice? And although, of course, coming out is not always necessarily relevant to a healthcare professional, it depends on the context. It depends on the reason why we are in a healthcare context. But so it is actually quite interesting and important that a large number of people say, I deemed it irrelevant, because it is actually irrelevant, or it may seem irrelevant in many contexts. However, I will point my attention to these two second points. One is, I was afraid that coming out might affect the way I would be treated. And so there is already a hint that there is a preventive fear that coming out might affect negatively the way people are treated. And in fact, another good number of people also respond, I was afraid to be discriminated against, which is more a way to put it more bluntly. I also think I also find interesting that some people also pointed out that they had no energy to speak about it, because something that we also need to think is that in the moment in which we access healthcare, we are in a state of vulnerability, and not everyone and not in every moment we might have the energy, the mental space, the source of strength to come out to speak about something that may be actually affecting the way we are treated. And indeed, in healthcare settings, people often choose not to come out due to a number of reasons. probably the most common one is that they feel vulnerable, so that they feel that disclosing their sexual orientation may increase this sense of being exposed or being in someone else's hands during a time of distress. But it is also a choice that is done depending on the type of support networks patients have. So some LGBTQ plus people, for example, pointed out that they go to the doctor together with their parents, and not all parents are supportive of LGBTQI identities or may not want to speak about that in front of the doctor. And so this can discourage people to actually come out in the relationship with the healthcare professional. And then this point about preventive fear of discrimination, which I'm going to unpack a bit more in the next minutes. And it is significant that this feeling might not be generated by actual previous experiences of the discrimination, but everyone knows someone that has been discriminated against. There are stories shared with friends, with comrades, with other activists, and there is, of course, an experience of social pressure, and of course there is an incorporated, embodied experience of discrimination in other areas of life. It may be the workplace or the family or the public space. So all of this contributes to foster the feeling that there is something to be afraid of. Even if it never happened, it may always happen. That you really don't know when it will happen, but it's very possible that it happens. And this preventive fear is actually ever present, and we will see some examples of that. And finally, again, it is not a point I can address today, but there is also some mention about the fact that since nobody ever knows whether they're treated by an LGBTQ plus healthcare professional, they also don't feel safe in sharing their own positioning. And so there is this also this lack of information, of representation in public, for example, in posters, in websites, and medical information, reinforces the idea that, as a participant says, the system is not ready for me. Okay, that LGBTQ plus people basically don't exist within the healthcare context. It is also important to point out that the constant need for screening the situations, reading the context, making decisions about coming out, interpreting the hidden signals, or even predicting the consequences. It is all a set of activities, a constant screening activity that fuels, of course, stress and anxiety, especially in some people that may also be experiencing stress and anxiety due to their worry for their health condition, or because they are in a situation of mental health distress. So, but it is useful to remember as a starting point something that may be very banal, but one of the participants, Zara, puts it down very, 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 very well. It says, in general, if I'm going to the doctor, it's because I'm sick. And if I am sick, I'm anxious about what I may have. So it is a very, how can I say, blunt and clear starting point. So there is an underlying preoccupation and worry and concern when we are accessing healthcare. And on top of all that, some LGBTQ plus people, or most LGBTQ plus people, may experience that screening, that anxiety I was talking about. However, it is important to point out that several participants also talk about strategies to navigate invisibility, or as we could reframe it, to actually tame visibility and what comes with it. Sarah, for example, mentions something important and says, I come out because I have the privilege of being able to pay the 65 euros, file a complaint about the doctor, go next door and book another appointment. And that's why I don't have a problem with it, and why I make a point every time of coming out. If I can, of course, yes, which I usually can, because there's always that conversation about your partner, your home, who you live with. There are always those little chats where your sexual orientation becomes clear, end of quote. So Sarah mentioned something that is quite interesting about visibility, and it has to do with the economic privilege of accessing, of having the possibility of accessing a private alternative to the public system in case something goes wrong, or in case she's discriminated against. And so this economic privilege sort of provides self-confidence, a sense of protection, even, I will say, the courage to actively challenge the healthcare professional if it's needed. And of course, it's essential to recognize that not everyone has the same ability to navigate these conversations, or may not be in the same economic situation, or may not even recognize the economic condition as a privilege. But it is indeed very interesting to see how the fear, the preventive fear of discrimination, may be overcome through this acknowledging of the economic situation. Another interesting nuance to disability, to the way of participants actually deal with the issues of disability, is the one provided by Antonio, who states, when it's not necessary, I don't say anything, right? I don't come out. But if there's an uncomfortable situation as a gay person in a healthcare setting, then yes, I do come out, partly so that the other person doesn't make me feel uncomfortable at a moment when that's the last thing I want to feel. So, and it is interesting to connect this excerpt to another moment of the interview, in which Antonio says something about his fear for the future. And he says, I'm quite afraid, for example, I worry about having an emergency situation where I'm unconscious and being discriminated against or judged, or receiving worse treatment because of my sexual orientation. Yes, I'm really quite afraid of that. So again, the topic of fear comes back. But in this sense, through this second sentence, the second excerpt from Antonio, we can see actually that the act of coming out can become a crucial tool, not just for personal identity, but I will say as a mean to protect oneself, advocate for a better treatment, but also to put in place what's needed to be protected in case something goes wrong. And so somehow it is an act of radical self-care, one that acknowledges the risks and the fears connected to them, but also turn them into a tool of action. So literature on LGBTQ plus experiences in healthcare, as I mentioned, often highlights that the structures that build health systems as a whole are based on strong cis heteronormativity. And actually this reflects on the way expectations and relationships are built within the healthcare settings. And in the questionnaire, we asked, have you ever noticed in the context of a consultation, hospital stay, or medical examination that healthcare professionals assumed you were heterosexual and cisgender without asking? And the large majority of respondents say always, 1/3 of them, they state it always happens. And together with them, there's a 16, almost 18% that actually state often it often happens. And then also some a reduced percentage of people say it may have happened, but I'm not sure about that. So it is important actually to connect this data to some similar results that emerged when we asked, have you ever been treated by a healthcare professional that was openly LGBTQ+? And most of the people in percentages that are quite similar to these, they responded, no, it never happened. So, you know, you see this system based on cis heteronormativity, reproduces the invisibility, and it does it so structurally, reproduces the invisibility of LGBTQ plus people, and on all grounds. It's not something that has to do only with patients, because it is something that the healthcare system inherited in its roots, in its basis. And of course, these assumptions generate some sort of discomfort. And Sarah describes this discomfort as such. So the doctor asked, she's referring to a specific moment during a medical consultation. And she says, the doctor asked all those standard questions. Do you take contraception? And I make a point of making them realize what's wrong with their approach. So when they say, do you take contraception? I don't reply with, no, I'm a lesbian, I don't need it. I just say no. And then the next question is always, are you trying to get pregnant? And I say, no. And then they ask, are you sexually active? And I say, yes. You see, I go step by step like that to see if they finally understand how uncomfortable it is when they're not prepared to receive you properly. End of quote. So Sarah intentionally engages in this step-by-step dialogue to illustrate how uncomfortable it can be when professionals are unprepared to receive diverse identities. And so it's not just about answering questions in a certain way, it's also about sort of dealing with the conversations in a way that uncovers discomfort, and in a way in which discomfort is sort of shifts from Sarah to is transferred on the shoulders of the healthcare professional. And so it's also about challenging assumptions and fostering sort of a more inclusive way of doing practicing within healthcare settings. Of course, this way of challenging and sort of having this relationship with healthcare professional is not always easy, and not everyone has, as we said, the energy or the privilege or even the cultural and socio-cultural background to be able to do this. And another strategy that emerges is the one in which LGBTQ plus patients take the time to educate their healthcare professionals when they show ignorance about some topics. And Lucas, a young trans man, for example, explains a situation that he went through. He said, the doctor brought up this issue, like, I don't know what to do with you, where I should place you, whether to place me in the female or male ward. And I wasn't expecting that. Nobody knows how they react until it happens. And of course, she doesn't have to have my experience. No one does, right? But in that moment, I felt it was quite intrusive even. And honestly, I didn't quite know how to respond. Of course, eventually I did. But there was a moment when I felt quite confused, like, okay, how do I deal with this? Because it hurt too, right? To me, there was no doubt if a decision had to be made based on gender, I will be placed in the male ward, right? And that's the feedback I gave her. So we talked a bit about that. But I could see there was some resistance to shifting her perception of this reality. Anyway, I hope this helps in some way. The solution she came up with was to place me in a room on my own. End of quote. Now, this experience, of course, was felt as intrusive, and it stirred feelings of discomfort for Lucas. And of course, it's important to recognize these moments can be incredibly challenging for many. But Lucas decided to overcome it, to overcome this initial discomfort and also confusion, as he says, and provides a sort of extended feedback, empathic feedback to the doctor. So he also acknowledges retrospectively that the doctor may not have had access to the information they needed, and so Lucas does not blame the doctor for not knowing something that actually she should know. And so what Lucas does is to provide this feedback in the hope that this helps in some way, especially for future patients. And so it is really interesting to see how this discomfort, this confusion, even this feeling of being hurt is somehow transformed again as a tool to sort of change things from an individual place. And Lucas did that very quickly. However, we know that it is not only an LGBTQ plus experience. It happens a lot with racialized patients, with people with disabilities, and others, that whenever someone is put somehow categorized within a minority perspective, in a minority group, they are often expected to educate their oppressor somehow, and so it is, of course, challenging to read something like Lucas' experiences and don't think about also this other side of that. Then there's another topic that often emerges, as I told you, is the treatment adherence. So how patients are actually willing to follow medication, to take their medication, to go to consultations, to do their routine exams, to participate in screenings. And something that literature often shows is that LGBTQ plus people tend to have less treatment adherence. So they try to avoid going to the doctor as much as possible. Of course, this is a broad generalization, but we wanted to understand how this happens for participants to the questionnaire. And actually, although 60%, and it is a good number, said that they never have avoided or delayed a consultation, a treatment, or an examination out of fear of being discriminated against, there is also a percentage that shows that this is something that actually happens. For some people, it happens sometimes. For some people, it happens rarely, but still it happens. And for a 4% of people, it happens often, which I think it's quite worrying to think about. But how does this reticence translate into actual practices? So that there's this experience by one of the interviewees called Sol, which is who is a non-binary person, and they tell their experience as such. I developed these patches on my stomach and chest, and I haven't had top surgery yet. So I didn't want to go to the doctor because I will have to show my chest. And I was afraid they might be transphobic. So it took me 3 weeks to be able to go to a doctor, which is an ideal. I ended up seeing a doctor who was recommended to me by activists. Sol is in contact with a network of activists, is an activist themselves, so somehow found a way to sort of navigate the fear of actually accessing healthcare. But of course, this delay in accessing these 3 weeks that Sol waited is not just inconvenient. It can have serious implications for one's health. So the network of support in this case was really important in solving the situation. But I will say that this experience also shows how subtle and how crucial this feeling of preventive fear may be, and the extent to which it influences access to healthcare services. And of course, it also shows that we are not only talking about individual experiences. If we sum all these individual experiences, experiences such as the one told by Sol, we actually see the bigger picture. And the bigger picture is that we may be in front of an actual public health issue in which we have a large number of population that should attend screenings or that should take care of their health for some reason and are not doing this out of preventive fear. And I will say that this is a very, very important issue that needs to be addressed. Finally, and just heading to my final conclusions, I was particularly struck by the recurrent idea that going to the doctor is like going to the battlefield, that people need to get ready to go, that the preparation to access involves a series of practices. So, for example, Martha says, I try to think of the worst case scenario. If they react really badly, what do I do? So I file a complaint. That's it. I mean, I don't know many formal procedure, but what I think is I go to the reception, try to speak to the manager, and if it doesn't work, I send an email, and if it doesn't work, I make a phone call, and if I can't call, I'll go there in person. One way or another, the complaint has to reach someone. And Antonio, for example, has another strategy to get ready to the battlefield. Antonio says, this is what's expected, to be able to speak to a healthcare professional who answers your question, not someone who fuels panic. So now, whenever I go to the hospital, I make sure I get informed and re-informed about everything. And further in the interview, Antonio even jokes about the fact that he takes a master's degree in his own health every time he has to go to the doctor. But this, so we are, of course, talking about a sort of mental training of accessing, preventing information, accumulating knowledge, screening all the possible scenarios, especially the worst case scenarios. So getting ready for something that may go wrong. And other two important aspects here are in the first place, in the case of Martha, the importance of having a legal framework or having some tools to, in this case, for example, file a legal complaint. So in the case of Portugal, the importance of the existence of a national health strategy somehow protects LGBTQ plus people from just regular discrimination, because they know that there is a legal framework that actually recognizes they may face this type of situations. And in the case of Antonio, again, the sense of safety is not provided by the economic status. In the case of Antonio, I had to cut the little part in which Antonio was saying also, I need to make sure that I know everything because I don't have the money to pay for a private healthcare access. So, and the way Antonio gets ready to the battlefield is using knowledge as a tool to confront and to challenge what happens in the healthcare system. And of course, this idea of the economic privilege that comes back again is particularly important, not only in Portugal, but also in other European countries and in the UK, where the pressure of neoliberalism on healthcare and on health services is transforming the way people make their decision about their own health and creating new inequalities and sort of more complex inequalities. And indeed, when we talk about going to the battlefield, when we asked whether going to the doctor, accessing healthcare is a source of emotional stress, most people said it is always. 16% said it's always stressful. 23% said it's frequently stressful, and well, 40% said sometimes it's stressful. But overall, a large number of people actually feel that it's stressful. And after this presentation, probably you understand a little bit more of why it is stressful. Of course, there are other topics that I didn't have the time to address that have to do with the specificities of older LGBTQ plus people within the healthcare system. They have to do with the impact of COVID-19 pandemic and the access especially to mental health care services. And again, the idea of how we complexify this data through an interdisciplinary and intercultural and intersectional lens. And again, the economic inequalities. But these are all topics that may deserve a bit more time that today I don't have. So in conclusion, the preventive feelings of fear, of reticence, of anxiety play a significant role in how LGBTQ plus people navigate healthcare settings. And this emotion can actually deter individuals from seeking necessarily medical attention, and they can impact their overall health and well-being, and actually radically influence the quality of the treatment they receive. And in second place, as the study indicates, LGBTQ plus people show great capacity to grapple with the complexity of navigating the healthcare system. So their strategies often put self-care at the center, and as we have discussed, a proactive challenge to the overall system. However, somehow the collective dimension of that is missing. These are the actions and strategies and practices that seem to stay on an individual level. And so one of the questions I have will be, how do we go to a collective dimension? How do we translate this to a collective mobilization somehow? And of course, more research is needed in general. And of course, and this is an ongoing project, so we are still collecting other data, but more research is needed on how people feel, how people navigate their feelings in the healthcare settings, not just about the structural layers of inequalities that they may actually encounter. And of course, when we talk about LGBTQ plus people in the healthcare system, there's always a moment in which someone says, healthcare professionals need more training because they're not trained, they don't receive enough training, which is true. But it seems also, at least from what the study conducted shows, that it is crucial that this training to healthcare providers has a specific focus on these invisible aspects, on these socio-emotional aspects, on these preventive fears, on these preventive concerns, on the sense of shame, on the way pride is used as a strategy. So only in this way, training can actually empower healthcare professionals to create a more supportive environment for their patients. And I will conclude like that. And I thank you very much for your attention, and you're, of course, very welcome to make questions or challenge what I presented, and contact me if you want.
Thank you, Mara. Really great talk and loads to think about and talk about there. So thank you very much. We have plenty of time for questions, so I open it up to the floor, and you're welcome to raise your hand and ask your question, or you're welcome to type it into the chat. While we're waiting for people to gather their thoughts, I can jump in because I really like the emphasis on the kind of preventative emotions, and like the anticipation of emotions is something I've been grappling with, like phenomenologically, because anticipating an emotion is not the same as experiencing the emotion, and often it becomes invisibilized in experience because it's not happening. It's something that you're anticipating, but it's not realized. And so it's a really great piece. I just really enjoyed that part of the research and the testimony of like bringing this kind of present absence to light through the testimony of your participants, because it's not present, then it's not really acknowledged. And that kind of anticipation of an emotion can, and I've written about the anticipation of shame and how that can drive decision making and behavior just as much as a full-blown shame experience can. But because it's visibilized, you don't actually take it into account. And that's so powerful in a healthcare setting, where it can be the thing that stops you from attending clinic or disclosing fully, and so on. So it's kind of more of a comment, but I really liked that focus on the anticipation of a type of treatment, or an anticipation of a type of emotional interaction, or an affectively loaded interaction that drives the sorts of decisions people make when they're accessing healthcare. So thank you.
Thank you, Luna.
Any other questions or comments? Emily has written something there in the chat. Other than training for healthcare professionals, were there other solutions to these issues discussed in the interviews at all?
Thank you, Emily. Actually, part of the interview was focused on exactly asking people, what do you think could improve? What would you like to see in place? And also to discuss somehow, sometimes I will also bring up some examples from other countries, other settings in which some practices are already in place, and sort of ask people and encourage interviewees to sort of comment on that, and think about that, and because what happens is on one side, interviewees were very open and very aware of what is not working, but the same awareness was probably not felt by a lot of people in what could be changed. So some people actually showed that a very small thing, like if healthcare professionals wore a badge, a little badge or a little pin, you know, with a rainbow flag, which I know it's something that in the NHS, for example, is used, or in other countries as well. It happens here in Portugal. It's not a common practice, but many people refer to that as a very small gesture from healthcare professionals that will make them feel more welcomed and sort of ease their stress and their anxiety, because it will show that at least the healthcare professionals acknowledges the existence of LGBTQ plus people and may be or not prepared to address questions and issues, but at least, you know, it shows an openness. And also other recommendations sort of that we collected were regarded the use of more information and representation in all of the information that is shared within healthcare settings. You know, all the posters and pamphlets and flyers and websites and social media, in which in most cases LGBTQ plus people such and like other minorities do not appear. Simply they don't appear, they're not in the picture, they're not represented, or and this could improve a lot also the trust that people build in their access to healthcare. Of course, then there are more controversial measures that we discussed with some, one of them being the creation of lists of public lists of healthcare professionals that actually have training on LGBT plus issues. And this is a controversial practice because, of course, whilst some recognize that it is important, you know, that I know that a dermatologist or ophthalmologist has training on LGBTQ plus issue, this may discourage actually other actually acknowledge that this may discourage the access to healthcare as a whole, because then it will create different sort of entrances for LGBTQ plus people and not. And of course, healthcare professionals may have a good training on LGBTQ plus issues, but then not be absolutely prepared to address other types of intersectionalities, such as aging, for example, or disability, or racial issues. So, you know, this is, for example, a more controversial issue. But what I really enjoyed was, for me at least, it was to actually discuss with them, to see how, you know, each interviewee, each participant could start from a place of recognizing this anticipation of fear, this sense of discomfort, and actually transform this and take the time to think about, okay, but in an ideal world, what would I do? What would I like to see in my doctor's office? So.
Thank you for that answer. And I really like that, like just wearing a little pin can just change the kind of whole
Yeah.
dynamic and emotional atmosphere. And like often I laugh at solutions that are like, oh, we just get a t-shirt. But actually like this does seem like a meaningful but very basic intervention that can put people at ease. So it totally transforms then the interaction that unfolds. So thank you for that. There's another question in the chat, which I'll read out just for the recording. Talking about invisibility can also be understood as being related to the gender of the healthcare professional, whether male or female. At least that's how I feel. When I'm attended to by a male or female healthcare professional in Portugal, specifically in Coimbra, I immediately notice a difference in how I'm treated for being a non-binary person who uses she, her pronouns.
Yeah, thank you, Yuri, for this comment. It is absolutely
Mhm.
an issue, a topic. And actually, with some bisexual and lesbian participants, for example, we the relationship with the gynecologist is an issue that is recurrent. And so I'm now remembering one of the interviewees that said, I don't really care if my gynecologist has a specific preparation or training on LGBT issues. I just want it to be a woman. And this also offers another nuanced perspective on the fact that being LGBTQ plus is just only one of the of the many embodied identities that we bring with us with our body when we enter healthcare. And so some may be more relevant than others. But thank you for the comment.
Any other comments or questions? I just have a quick question in terms of like the future data collection. Does it have a slightly different focus, or is it more of the same focus?
And no, actually, the second phase of the project is focused on healthcare professionals.
Mm-hmm.
So, besides what this current phase, the second phase, is aiming to do is actually listening and learning through the experiences of healthcare professionals. Also, because
Mm-hmm.
the intention is not to demonize the healthcare professional as such, and which is something that sometimes in the LGBTQ plus community, I feel that there is some sort of demonization or some sort of us and them
Mm-hmm.
situation, and the final objective of the final aim of the project is actually to bring together patients and activists and healthcare professionals to design best practices together. So now the first phase was to listen to the LGBTQ plus patients. Now we are listening to the healthcare professional experiences. Then we will work together with activists and organizations also to gather data with them. And then at the end, we will put all together and hopefully make a contribution to improve healthcare in Portugal and maybe even outside.
Yeah, and I'm sure it would be a model for how to do similar interventions in other national contexts. So it sounds really important. Emily's put in a comment about connecting with Lisa Coombs, who I don't know, but thank you, Emily. That's helpful, I'm sure.
Yeah, any connection, is always welcome, especially because this is not a field in which many of us work. So I'm always excited to know more, and yeah, to connect.
Great. Are there any other questions or comments for Mara? Because if there aren't, we can wrap up early and give everyone some of their afternoon time back. And I'm sure you'll be happy to hear from anyone via email. And as I said, this talk will be on our YouTube channel. So we share the link on social media, and we'll share it with you, obviously, Mara, and also in our newsletter. So if you have a colleague or friend who might be interested to listen to this talk, you can watch out for that recording and share it. And I'd just like to thank you again for coming and speaking to us. It's been such a pleasure to see you and to hear this great talk. So thank you.
Thank you so much for the invitation, and thank you to everyone that's attended.
Yeah, and I'll see you soon. Thank you. Good afternoon.
Thank you.
Bye.
Bye.